Welcome to the breakout session on the power of big data in improving population health. As you know, this session is part of UKTI's Big Data Day. My name's Natalie Bateman. I'm Head of Health and Social Care and Local Government at techUK. We are the leading trade association for the tech industry in the UK. And we're delighted to be chairing today's session in partnership with UKTI. Our overall vision is to make the UK the leader for the development and use of technology to deliver benefits not only to the UK economy but also to the citizen. One of the biggest challenges facing governments today is around improving the health and well-being of citizens. You've got people that are living longer lives and not necessarily always living for healthier and better lives. And you see that there are examples of the use and development of technology to start addressing some of these challenges and issues. But I think there's still a real need, particularly in the kind of financial environment, to look for intelligent systems that can deliver reduced operational expenditure and cost, whilst also thinking of kind of creative ways of using and creating the data and analysing the data to help deliver kind of efficient services for patients. So that's the focus for today's session, is how we can start to address that and maybe kind of, look at some of the challenges and opportunities that are involved in that discussion. Without further ado, I'll introduce my three speakers to the right-hand side of me. So we've got Mark Davis, who is European Medical Director for MediAnalytics, which is a leading healthcare performance analytics company. Mark has extensive experience in informatics in healthcare, having worked in relevant roles in Department of Health, Cabinet Office, and most recently as Medical Director for HSCIC. He's also worked for Connecting for Health and the Choose and Book programme. However, recently, in May this year, he decided to move to the private sector to work for MediAnalytics. We then have Richard Ward, who is Director for Government Programmes at IBM UK. He is also Industry Chair of the Data Protection Working Group for techUK and for the Data Protection Group of the Digital Policy Alliance. Richard is responsible for IBM's government affairs programmes in the UK. He has a particular interest in data protection, cybersecurity, and on the impact of regulation and innovation. Last but certainly not least, we have Stephen Shelton, who's Director in PwC's Data Analytics Division. He's spent the last 17 years running data analytics and information management programmes for organisations across telecoms and media, healthcare, retail and transport sectors. He recently joined PwC from BA Systems, where he led their big data practice. So I've asked each of our panellists to provide some opening remarks on the importance of big data in the health and social care sector and where they think we can maximise its value. Following which I will open it up to the floor for a discussion. And on that note, I'll hand over to Mark in the first instance.
Thanks for that introduction. While I'm sitting down, you don't need to stand up here. I'm going to say a few words setting this in context, and I'm going to attempt to be provocative and contentious, because I think this is a subject that we should be having a valuable debate about. And I put it to you that actually health analytics and big data in healthcare is important for two reasons. Firstly, it will save the NHS, and secondly, it will save patients. It will save lives. And that might seem very dramatic and a very bold statement, but I'm going to spend just a few moments just kind of explaining what I mean. It doesn't matter where you go in the world, the challenges of healthcare are broadly similar. And we're very familiar. Adrian was alluding to them earlier on in his keynote. But essentially they're around kind of changing demographic challenges, a burgeoning load of long-term conditions, and indeed doctors like me inventing new and expensive ways of doing things. And all those things put together mean that we have reached a tipping point in terms of financing healthcare, and it doesn't matter where you look in the world, where the cost of healthcare and the requirements of healthcare have reached a tipping point where we cannot carry on delivering healthcare in the ways that we are currently doing. Something has to change. we've reached a political crisis point where people are starting to have some hard-nosed decisions around prioritisation, around service provision, and around the things that we can provide, both at the point of care and at the population level. And without actionable and insightful analytics and information that enable us to do this, we will not be able to do two things. We will not be able to make judgments around what the best things are to do, and frankly, we will not be able to take the public with us in that mature dialogue. So this is a very significant stuff, and it represents a significant shift of power across healthcare in two important ways. The first is a shift of power from those traditionally who have provided healthcare to those who plan healthcare, purchase healthcare, and prioritise healthcare based on local populations. We happen in the UK to call that commissioning, but it has different names in different parts of the world. Certainly in the UK we have one of the most provider-dominant healthcare systems in the world. And a lot historically we have tended to, incredible though it sounds, plan the provision of healthcare based on the organisations that we have in place to provide healthcare, as opposed to a meaningful assessment around the needs of a population, mapping those the needs of the population to the resources that we have available, doing that as part of a mature dialogue with those communities and neighbourhoods to understand some of the priorities, and using that to drive some conversations around the model of provision that will best set those requirements. Therein lies the answer to how to effectively plan healthcare, but that requires, as I say, actionable intelligence. The other shift, which is perhaps more interesting, certainly to myself, is the shift from the system to individual patients and indeed to communities. And I see big data as being an important part of that. It's an important part of measuring what is effective, measuring what's done well, and doing it in a transparent way, in an open way that takes both individual patients on a journey with you to understand their own care, and indeed neighbourhoods with you to understand planning and prioritisation and service to redesign in particular localities. So that's what I mean about data analytics saving the NHS. I spent most of my professional career as a clinician working as a general practitioner, and it should make most of you feel uncomfortable in the room. But I think when I was working as a general practitioner, probably the evidence that we had predicted about 30% of the things that I did. So for about 30% of the time, I had a good evidence base for what I was doing. So for 70% of the time, you're all looking a bit uncomfortable now, actually. For about 70% of the time, I was engaged in something of a natural experiment. And I would argue that in doing that without systematically capturing outcomes, without systematically capturing indicators and measures of quality of care, and to do that in the context of financial allocations, so we get into the whole issues around value in healthcare, to continue to do that, I would say, is unethical. So the value of big data and analytics is around capturing those outcomes and as creating systems actually that learn, creating systems that inform what best practice looks like, and doing it in a way that is open and transparent.
How do you define value in healthcare?
I'll
come back later.
That's a great question.
I'll come back later.
I'll skirt round that question beautifully by just quoting the kind of Harvard Porter School, which is what I mean by value.
Is that the Porter definition?
Yeah, which essentially outputs that you get for unit of resource investment, if people aren't familiar with Porter's work. And I guess so that's what I mean around kind of the value of data and saving the NHS. What about saving lives? You know, as a GP, when I was training as a doctor at the turn of the last century, childhood leukemias had a mortality of about 60%. So we used to cure about 40% of kids with leukemia. And actually there were about 6 leukemias then. This is 30 years ago. We have revolutionised paediatric oncology internationally. And we have done that through the effective application of analytics and data. Probably doesn't meet the criteria of big data or medium data, but nonetheless, the effective use of analytics saves lives. If, God forbid, one of my children develops leukemia now, the chances of them being cured is of the order of about 90%. So while we're having a discussion around some of the risks associated with using data, we're going to have a really important discussion around kind of information governance and privacy, and some of the issues around some of the kind of very significant risks associated with big data. I just want us to have no doubts around the kind of benefits of this, because I think frankly it's very difficult to overstate it. I'll just say one final thing, and I think it's kind of one of the most interesting things around big data, and often actually in health we haven't really gone. I think we're at the kind of medium data level at the moment. We haven't really done things to the side of the big data. But some of the stuff that is most interesting about this is our ability to connect with small data. So the burgeoning amount of data that will emanate from monitored self, the amount of personal data around patient experience, the amount of personal data around genomics, and the personal data around lifestyle will start to contribute to our data landscape in a way that, frankly, most of us find difficult to imagine. And I look forward to a time, actually, where we have an information architecture that has as its inherent currency individual people. And we start to understand healthcare in terms of patient journeys and patient experience on a very granular level, as compared with the currency which is currently large organisations. So it's a very exciting time. It offers massive potential. Clearly there are issues around privacy and our mature engagement with the public around how we manage data, but I think it is difficult to overstate the benefits.
Okay, thank you. I had to make a few notes in order to try and keep myself to time. If any of you have heard me speak before, you'll understand what problem that can be. But essentially I wanted to make 3 points. One was to talk about big data and health and social care currently. Then with just a few spots and examples. I also want to talk about the impact that new technologies coming down the track have started to deliver and will deliver in future. And then also a few comments on the need to bring the public with us in the whole use of big data in healthcare especially. So I think there's no doubt that healthcare providers around the world and the NHS of the UK are delivering benefit already. And we've heard some of that from Mark on the collection of big data and the collection of data and its analysis. And there are some, I think, examples too of using data down at the personal level as well. Like, for instance, instead of patients being checked on a sort of batch basis every hour to check their particular indicators, then they can be monitored automatically on a continuous basis. So it's really pulling out information relating to that individual. When we look at the use of big data, there's some good UK examples, I think, and I don't mean to pick these out as being much better than all of the others. They were simply some examples that came to mind. So when the UK's prescription data was analysed by Nesta and Mastodon C, then what that showed was that for many GPs, it takes several years for them to catch up with the latest NICE guidelines on prescribing. So by a simple look at the prescription data has some quite insightful observations. Now, how you fix that problem, of course, is something else, but actually, at least if you're aware of it. One, I think probably also interesting use of data is if you actually analyse health record data to look at the factors that predict heart disease risk, then you will find that early signs of heart problems were actually being documented in people's records sometimes years before a heart diagnosis a heart disease diagnosis is made. So actually, if you could get insight into those factors, you could well predict that someone has a high risk of heart disease developing, and fix that problem, or try to intervene to fix that problem before they actually develop it. Now that's obviously complicated by the fact that there isn't just one thing that you can pick on and say, aha, everybody who shows signs of this has a high risk of developing heart disease. It's a much more complicated picture, but actually there's a chance for intervention. Another example, currently working as well using current technology, the Harvard Medical School using data analytics to look at the continuous monitoring of drug effectiveness and safety. So when it's prescribed, what effectiveness does it have, and is it safe? So no end of examples, I think, of kind of some traditional use of data, which sort of leads me on to my next point, which is I think we can really expect to see new technologies continuing to transform healthcare. So those examples I've talked about are really based on traditional, what we might refer to as programmatic systems. So they're systems that have been really good at handling traditional structured data, and they follow programmed instructions. And they do it in a very trustworthy and stable and predictable way. So generally, if you put the same information into it, then the same result will come out time after time. The problem is those kinds of systems don't really respond to a lot of the problems that we face in healthcare. So those sorts of systems can't read through millions of pages of medical research. They can't cope with the doubling of medical information every 5 years. And they give you an answer. They can't give you an answer that's related to the patient that you actually have in front of you. What they can do is do a kind of sophisticated keyword search and then bring you up a list of potential options. So the way that in IBM we see the use of data analytics in medicine particularly moving is in the use of cognitive systems. So cognitive systems are not programmed, they're taught how to solve problems by doing practice examples, and they learn from experience. So they interpret unstructured data like languages and images and apply it where there are no clear-cut answers. Now for IBM, and a number of other companies are looking at this too, but for IBM the journey here started with a system called Watson, which we put into the game show Jeopardy. And well, I won't explain a lot about Jeopardy. If you know it, then you'll understand it. If not, it will take us a few minutes. But it's effectively, the system has to understand subtleties of language, it has to understand puns, and very quickly it has to respond with an answer against which it's assigned a probability. So it has to be confident it's got the right answer before it answers, because if you answer and get the wrong answer, you're penalised for that. So there's no point in just coming up with the best fit if in fact it turns out to be wrong. So the first practical use of that kind of technology for us was in healthcare, and really we began with oncology and looking at providing better individualised patient care plans. So the first iteration of this was looking at evidence-based treatment options. So we set up a system with a US hospital, as it happens, which will, given the patient information, will go through 2 million pages of text, usually published papers, and 600,000 pieces of evidence based on patient cases, and quite quickly, within 3 seconds, come up with a list of hypotheses, along with the evidence that supports those hypotheses, and the confidence rating for each of those. So it's very quickly, and we already heard, for a lot of the time, clinicians are not actually making evidence-based decisions. So it gives them the opportunity to make evidence-based decisions by simply going through all of the potential information that it has access to. So you've got a list of ranked treatment options rather than just a list of valid choices. So we're then moving on to using the technology to look at particular gene sequencing mutations, so you can base the patient's treatment plan also on genetic profiles. So I think we're starting to see a whole array of different uses that the different technology starts to bring. So enough on that. My third point really is on the importance of bringing citizens with us. We've heard quite a bit about that already this morning. I think that it's true that the UK represents a really great place to take advantage of big data in healthcare. We've already heard the government's committed to the idea of open data, and it's making a lot of data sets available. The government is also committed to the idea of data-driven science, and maybe as an observation from a global organisation, I think one of the things that the UK is very good at, which sometimes we take for granted, is having academia and industry and government working together in collaboration. And I think that is not so true in very many other countries in the world. And dare I say, one of the countries where it is quite difficult to do that is the United States. So I think that it's a good place to encourage progress, but I do think without the support of the public, we really won't make the progress that we need to make. And this brings me on, I think there are two areas that we need to focus on here. I think first we have to convince the public that there are trustworthy organisations who will be ethical custodians of their data. And that involves that happens at a number of different levels. The first level, I think, is what we might call just basic hygiene, which is their data stored in a safe place, secure from cyber attacks, secure from unauthorised access, and using the right types of technology or approaches to protect their privacy. So we heard a little bit this morning about something that I would define as data minimization, which is, if you need data for a particular purpose, then only store the data that you need for that purpose, and then when you no longer need it, then don't keep it. And you will have seen through articles in the press recently that actually those basic hygiene factors are not that easy. So some large, sophisticated organisations have suffered data loss as a result of cyber attack. But I think that's a very basic level that we should all expect. Then we move on to what ought to be the slightly more complex area, which is the idea of engendering trust through our behaviour. And for me, this is all about not doing things just because we can, but doing what the people whose data we hold think would be right. So that's about being transparent about what we're doing and why we're doing it, but also being willing to share some of the value of the data that we're getting from it with the people whose data it is. And I think this sort of moves me on to the second step of this. I think first of all, we have to prove that there are organisations who will behave ethically in their use of individuals' data. But I think the big issue here is we have to convince the public that there are benefits to doing this. And this has been successfully done in some commercial spheres. Supermarket charge cards were mentioned earlier today. You give your data over to the supermarket you shop at, and they get some benefit from it, and in return you get some benefit back. So it's not a one-way street. And by and large, they focus very much on not doing things which you would find unpleasant or surprising with your data. And so that's an important issue they need to deal with. But I think in the case of healthcare, there's a very explicit exchange, which is if your data is used for analytics in healthcare, it may well develop something that will save your life or could transform it. And I think collectively, I don't think that the responsibility sits in any one place for this. Collectively, we have done a terrible job at explaining to people why we want to use their healthcare data to develop new treatment options. Care.data, I think, is a good case study in how not to do this. And if the very best we get out of this is a 6-month delay whilst things are rethought, as Mark said earlier, the risk of that 6-month delay is that people will die who wouldn't have done as a result. And I think that's a disaster. So that's all from me.
Stephen?
Okay, thank you. One of the disadvantages going third is that you then sit in real time realising that what you're about to say, someone's already said already. But I'll give you my perspective. So I'll give you 3 groups of 4. Okay, so 4 sources of where I see or where we see the big data opportunity coming from, the 4 key benefits we think it might provide, and I think 4 challenges which we need to address, some of which of course you've heard before. So the 4, when we talk about big data in healthcare, I think we're talking about 4 things that we can see. One, starting maybe at the most big data end of the scale, is the whole revolution in biometric readings from wearable health monitors, bracelets, and that side of things, and the potential opportunity that could provide for proactive management of long-term conditions and real-time monitoring of condition. That's a, thinking in a 5-year timescale, a genuinely new source of data for the healthcare industry to use. That's the first source of data. The second source of data is genomic data. So we've had DNA sequencing for many years. In the first runs of the Human Genome Project, it was taking several weeks to run a DNA profile. It took several £100,000 worth of equipment. Now we can run individual DNA processing profiles at an absolute fraction of that cost. I mean, the whole story about big data, of course, is it's about ubiquitous computing and the complete commoditization of the cost of computing, and that cost has come down to make genomic data now, I wouldn't say trivially available, but commonplace available to parts of the healthcare system where it wasn't available before. That's the second source of data. The third source of data, of course, is the electronic patient record. So we've heard just about care.data, and the opportunities of bringing that data together for the first time to understand clinical outcomes and pathways and so on. And then the fourth source of data that we see you wouldn't class it as big data, but it's a data set which is only recently really becoming fully interrogated, which is all the various silos of information which sits around the care system. So now we've moved to care commissioning groups and pooling data from hospital trusts in with GPs, social local health teams. That as an overall data set in terms of understanding the optimisation of provision of healthcare into the community is a relatively new asset for us to look at. So those are the 4 sources of data. Moving on then to where are the 4 potential benefits. We've heard again, of course, some of these already, but first one will be around the individualisation of healthcare plans and the proactive management of conditions. So we heard from Natalie at the beginning very eloquently in the plenary session around how some of that could look, and I think we absolutely would concur with that view that's a really strong opportunity to really transform how we bring down the cost of long-term care. The second one I think is a slightly more, maybe transactional. It's not so much around managing health conditions, but there's a lot of interesting work going on around disease outbreak monitoring, for instance, and how we use big data to solve that. Public Health England and the Infectious Disease Research Network have got a session later this week looking at how we bring together mobile technology, genome sequencing technology, and various other bits and pieces to do real-time alerting on flu monitoring, so that instead of just recording cases, sending the thing off to a lab, getting it processed, and then eventually getting hoovered up into a monitoring system, in as near real time as you can getting to the exact DNA sequence of those outbreaks to understand where the outbreaks are linked to each other. So do you have an outbreak, or do you have multiple instances of different flu cases happening in different cases? There's similar work going on other notifiable diseases, things like salmonella, for instance, where you can start to see now much more quickly, much better information around where those genuine outbreaks are happening versus just clusters of cases which are just coincidence, for instance. So there's a sort of transactional view there. We've also, in terms of the patient healthcare data, I won't labour the point around being able to analyse the larger data sets to understand clinical outcomes and the efficacy of treatment. So we've heard about that before. That's certainly the third one. And then the fourth one I alluded to briefly as well, around the optimisation of where healthcare is delivered. I think one of the things we will need to address with big data is ultimately, in terms of working with the healthcare system, it's got to work with the existing data that the healthcare system collects. So how you stitch together community care data with hospital trust data, with GP data, to understand where care is best provided. We've already heard in the news there's potentially a policy move away from building big regional specialist centres for cases and moving more to a community hospital-based care system. And data is really going to be at the heart of how we plan that and how we do that for the best value. Four challenges then to finish off. The first is the privacy and trust issue. So we've heard about care.uk data. The only thing I would add to that comment will be the healthcare system. I think the care data experience did show a kind of lack of experience around how to maybe engage the public with the benefits of what's trying to be done. The healthcare industry is relatively immature, I suppose, compared to other industries who have gone a lot further down the pathway to resolving some of those challenges. And the one the industry I think was probably the most similar isn't the supermarkets, probably the telecoms industry, probably the mobile telco industry at that. So in the last 10 years, mobile telcos have become the custodians of extremely sensitive, very large lakes of data about us. Everywhere you go, your location, everything you do with your phone, everyone you call, everyone you know. And I've done a lot of work with telcos, and believe me, they see that as a real double-edged sword. So they can see the value, and it has value across the operation, not just in terms of marketing to you as a person, but just in terms of running the operations. That's incredibly valuable. But I wouldn't be exaggerated to say that at the C-level, those boards, they literally have sleepless nights around losing that data or being seen to really be misusing it. I mean, it's a really fundamental issue for them. But the net result has been they've had to deal with it. And the last couple of years, you may or may not have seen it with your own providers, but they've got a lot more clever and more mature around how they manage consent and how they communicate with people around what they're doing with their data. Now, there's still a long way to go with them. They haven't completely solved the problem. But in terms of what they're trying to avoid is throwing the baby out with the bathwater. So not get to a point where people say, don't touch my data, leave it alone, don't do anything with it. Get to a point where people are comfortable with them doing certain things and they can dial up or dial down the consent that they give. So some of the operators are now producing apps which do that for you to say, can we use your location data, yes or no? Can we share it with third parties, yes or no? Rather than simply saying, can we use your data, yes or no, which can often lead to people saying, just leave me out. So that's my perspective on the care.uk thing. I think there's room to look and learn from other industries on that one. The second challenge is really the state of the data, particularly within the NHS. I think we shouldn't underestimate that that's going to be a challenge. Anyone who's had the fortune to work with trust data, for instance, will know that there's multiple different ways of coding the same things. Hospitals often use the coding that is best for them in terms of their funding arrangements, and that's not a particularly cynical comment, that's a completely natural thing to do. It gets even worse when you try and do different trusts together with a GP, with a social care team, and look at how that data's organised. Very different. How we solve that, I don't think it's insolvable, but I think we can't ignore it and hope for the best. It will need some proper dedicated effort and concentration to get over that particular challenge. Third one, potentially controversially, in terms of bringing the public with us with the benefits of data, I'm not sure yet we've got the absolute killer proof points that we need to prove that this actually really works. I think there's lots of good work going on, and there was a couple of good case studies, but in terms, I think we're still at the stage a little bit of the concept. People are brought into the concept without being able to show the reality. There's a slight chicken and egg there. And we've got things which aren't helpful, like Google flu trends, which people see in the last couple of months has started coming under attack, and that it hasn't quite lived up to the promise that it had. It was probably a misplaced promise. It's Google, it's not a healthcare provider, and various things. But we've got things in the press now which saying big data doesn't quite do what people are saying it's supposed to do. How do we get over that hump? So I think we need some genuine, real killer proof points to help convince the public that it's something worth doing. And then finally, in terms of going back to my original data source around the whole biometric revolution and genomics and that kind of thing, how that really works with the NHS care system, I think is another problem we'll need to work out. I don't think it's necessarily a trivial question. So if you're a diabetic, you have a diabetic condition and you wear a monitor, for instance, and you monitor glucose and other things, how does the NHS actually use that data? Is it simply a readout that they get and the GP sees it once a month? What if you get an urgent indicator that comes up on your wristband? It needs more urgent attention. How does the NHS respond to that? Are they expected to build that into their response systems? Which part of the NHS is supposed to respond to that? What happens if they don't? Those are kind of governance questions which I think, again, they're not solvable, but we're going to need to think through in the 5 years ahead. That's it for me.
Fantastic, thank you to the three of you. So lots there to think about. I will open it up to questions now. So if I can ask, if you've got a question, to raise your hand and just say who you are and what company you're from, and if there's a particular speaker you want to address the question to, then say that as well.
My name's Professor David Hughes. I'm from Chester University. I'm also CEO of Health Economics Consultancy. It's a question of comment and observation. I'm glad we got to the last bit about big data. It's about the strategic context of this and how we use this. I mean, it sort of works on two levels at least, I think, in the individual sort of planning of patient care, but also zooming back out and looking strategically how the NHS is organised and do things. Because one of the challenges, worked with big data for 20, 25 years, it seems to me that it's almost nothing new within the NHS. It's existed. There's been a lot of these data around. One of the challenges is how the NHS actually does things better currently. It has challenges of technology, ageing population, and the disease profiles, but how it organises itself at the moment is one of the big challenges, and that's how we can potentially use big data. Now, one of the projects I was involved in, this was 10 years ago, was actually linking data. It took social care data, out-of-hours data, GP data, primary care data, and hospital data. Now, from a strategic level, the holes in it were manageable because they weren't that bad strategically. Okay, one of the two things weren't clinically coded correctly, we didn't have some of the tests that were done, but from a strategic level that didn't matter so much. So we did an analysis of why accident and emergency attendances were rising. So this is 10 years ago, it sounds very familiar, doesn't it? We did a whole systems analysis of this, and we found in the whole of an eastern region the same problem but different causes. So in one area it was out of hours, actually seemed to be shipping people to A&E. Another, it was access to primary care. Another, it was actually the success of the hospital itself, that people were seeing that the 4-hour targets were being hit and going to hospital, so we were victims of our own success. So we pulled these data sets together, and we had a big repository of data. Do you know what we did with the data at the end of the study? So we had data for covering a very large population. We destroyed it. So instead of building on it, we destroyed it. And that's the clinical, the information governance, Caldecott guidelines actually prevent us from using the data we currently have. The data have been around for a long while, and one of the pleas I'd have is we get our ducks lined up here, and for God's sake, don't collect all these data and constantly trip ourselves up and destroy the data that we've got to provide incredible strategic insights to address those very issues that have faced the NHS for a long, long while.
Mark, do you want to pick up on any of those points, particularly around kind of the big data is not necessarily new, but it's actually about how NHS does things
just
better.
to completely agree with what you've said, absolutely. I think one of the issues we've got is we have a very rich history of analysis in the NHS. You know, there's been some world-beating analysis that's gone on, and apart from the exception you just gave, one of the problems that we've got is that analysis has tended to be based around individual organisations. So it's been kind of marred by two things. One is it takes an organisational view, which isn't very helpful if you're trying to consider the needs of a population and to understand what happens to individual patients. And also it's tended to be very process and administratively orientated. So you know, if you're in the business of providing business intelligence to a healthcare system, I would sort of rather be of the view that healthcare system is about making people better and helping them stay well, and we should be providing intelligence around those things, i.e. outcomes. And we have tended to have analytic systems that have looked at where people have gone, flows of data, and where the money's gone, and what our reaction times are, which is kind of important, but it kind of sort of fundamentally misses the point. So the point that you made eloquently about kind of having a joined up view of a locality, I think is absolutely well made. And actually the point that we were making around sort of building some of the stories that will enable us to take the public and indeed patients with us around this stuff. It's in the joining up of doing those things that we will generate the evidence. And I suppose I slightly disagree with what you're saying about we haven't got the evidence. Absolutely, we need more evidence, but we have got really good evidence around data segmented stratification of the population, such as
avoiding unscheduled care, emergency admissions, working with individual cohorts of patients with conditions like COPD or heart failure, and targeting community-based interventions like matrons, etc. I could go on. There are lots and lots of examples of us using data to hone and improve the granularity and precision of us targeting interventions against and service models against particular groups of patients and improving outcomes. The problem that we've got is we haven't communicated those things in a way that actually captures the emotion and the imagination of my dad or my mum, you know. And we really are playing with fire if we don't kind of take the kind of emotional aspects of this as well as the intellectual access with the population, because frankly, you know, that's what happened in the finance industry. They left the public behind, and the banking industry left the public behind, and they left themselves in a difficult place. I don't think we're there now. I don't think care.data has helped, frankly. So we can pull back from that, but we need to learn the lessons of care.data and exactly as you say about ensuring that we take people with us.
And what's your view on the approach that government's taking now with care.data, for example? So obviously they had a 6-month pause initially, and then Simon Stevens came in and said, actually, if it takes longer, it'll take longer. We've got to get it right. Yeah. And they've got an advisory group that's looking at actually how they communicate that effectively to the public and clinicians. Yeah. What's your view on, is that the right, are they doing it the right way now? Do you think it'll lead to a positive outcome? And how long do you think it's going to take?
So you know, to sort of declare an interest, so obviously I was at the Health and Social Care Information Centre as the medical director while all this was going on. So I suppose I bear some of the scars around the care.data experience, though I would point out that it was commissioned from NHS England. I think that I was been really reassured to hear some of the noises that have come out, and you know, many of us were saying around care.data in the design stage that this is about a kind of cultural shift, and it takes as long as it takes. And actually, the public engagement and the public involvement aspects of this isn't a nice to have. It is actually the currency of what we're doing, and it will take as long as it takes. So to have Simon Stevens say, you know, we're not going to give a hard deadline of this that are often politically driven. We're going to actually evaluate it. We're going to do some pilots. We're going to work out how much buy-in we've got from the general public and patients around and what we're doing, and we will only go ahead when we're confident that we can do it in the right way. That isn't going to be a cheap thing to do. That isn't going to be a quick thing to do. But you know, I think all three of us have said that actually the moral and the ethical case for doing something like care.data is unquestionable.
Richard, Stephen, any additional thoughts on that?
No, I think that's covered all.
Yeah, I mean, I think you're right. In terms of the stories that we have, the evidence to prove this works. But just to build on that, I think just thinking as a consumer of the media and how the battle of the hearts and minds goes. We've got absolute tons of there's been projects, research, loads of things we're coming back on. What's the story which says this is the benefit, which is equivalent to the scale of the ask to the citizen? Yeah. So we're saying to the citizen, give us all your data, show us. I think if we have a myriad of small wins, that's kind of something, but we need the one that says, did you realise we brought diabetes, whatever it is, down by X because of this? And that will be the thing which people then go, right, I now understand.
Okay, perfect. Gentleman here.
Mark? Yeah.
Sorry, could you say who you are and what company?
Sorry, I'm John King from Ethos Health. My question, be careful because I'm sat next to an information architecture expert here, so my question is about information architecture. I understand what you're saying about the demographics, the financial pressures. The shift hasn't happened yet from provider to buyer, but it will happen. I won't get into value and quarter and all that, but I understand all that as well. But your point about information architecture, I don't quite agree with you. You focus that at an individual level. The shift from provider to buyer is only going to happen at a cohort level in terms of commissioning. So that architecture needs to reflect cohort needs that will influence the commissioning decisions. So it's got to be it's got to be cohort level as well as individual level if you're looking at it in architectural terms.
Yeah, and I don't think I disagree with you actually. So I suppose the point that I was trying to make is...
But it's both, sorry, I'm
Yeah.
not saying either
No,
or.
no,
It's-
sure,
sorry,
sure.
but
I mean,
it's not either or, it's both.
Sure. I mean, the reality is that we've got a perfect storm that's come together in the kind of requirements that we've got in terms of actionable health intelligence and the capabilities that we've got. I mean, just let's set aside the information governance for now. The capabilities that we've got in terms of processing clouds, and those two things have come together to give us as in a global healthcare set of specialists a fantastic opportunity. And my point is that rather than making the information architecture based on the organisations that provide care,
I agree,
we need to
the integration point.
we need to make the currency individual patients, and I would argue that we do that at the finest level of granularity, and we aggregate up on use case.
Yeah, agree with that.
Gentleman at the back.
Thank you. Angel Salazar. Had some academic at the Manchester Metropolitan Business School. I do research on the economics of platforms, and I also started a company, AI Technology, developing solutions for preventive health using digital technology. And I sympathize with all the challenges you are discussing about how to get around the users and the use of data and privacy and confidentiality. I understand those. The issue I wanted to raise is about that the UK might be losing an opportunity, a huge opportunity, and we want to be talking about the same things in 10 years' time, and just regretting that all the countries, maybe China, all the countries will be taking the lead on this, because we are constrained by the healthcare political system. We are under a tax-based system. The consumer doesn't have the same kind of motivation or drive or pressure to search for the better care, to reduce costs, to be healthier, like let's say countries like in America. And also they don't have problems. They have problems to implement the Affordable Act, in different states. But there are things that having a true market to promote SMEs, working with healthcare institutions, promote innovation and promote economic growth. This kind of market doesn't exist in the UK because it's filtered by the political system of our NHS. Investors don't want to invest because purchasing decisions are based on local managers that might change due to political agendas or periods, and then they don't want to take that risk. Till we don't have a real system that promotes more free competition in the NHS, I don't think we're going to be discussing about the same issues all the time.
So that's an interesting point actually around kind of the UK market in comparison to other countries as well, and actually are we missing the opportunity to be leading the way in this kind of area? Richard, can I hand over to you first for a response?
Yeah, I think that is it's a very fair point, and it's something that we can see from kind of sitting outside the healthcare system. I kind of, I struggle with what's the right way of fixing that though, and for me part of that is that the case for doing some of these things is so overwhelming that we simply have to make that case and try to bring about some organisational change. And I think that this has been alluded to a number of times, but we can do with today's technology most things that we want to. And as was said this morning, it's thinking of the questions to ask. It's not that the technology can't answer them for us. So I think it does, for me, come back at least to this question of building up enough of an evidence base, making it compelling. And I was reminded by one of the comments earlier that as a civil servant, and when we had a change of minister, I was always encouraged by my management to write a brief for the minister that my granny would understand. I think we really have got to make sure that we have a compelling case that generates the demand for change. I think if there's no demand for change, then we won't get it.
Okay. Stephen, any thoughts on that? Or Mark?
Two thoughts. So one. I mean, I know where you're coming from. I think what I think some people are looking at in the next 5-10 years is the personal health revolution rather than the provider health revolution. So self-management of health and how that works, and whether that market, I think, is, UK is known as the most digitally advanced country in the world, officially the most digital country, or by some metric, which I've now forgotten what it was, unfortunately. But there is something around personal healthcare management versus provider healthcare management, which I think the UK market maybe is as vibrant as any other. The second one, though, I mean, I'm not sure. I will defer to Mark on this one, but with all the challenges the NHS has, failure to technologically innovate, I don't know, is the top of the list. I think there's other challenges which maybe are focused on, and knowing some people in the medical equipment business and imaging business and that kind of thing. I don't think they feel overly constrained by the healthcare procurement system to provide new products to market. And of course, any medical technology provider, I guess, is never national anyway. I mean, we're all international businesses, so I don't know whether that's a genuine massive constraint on in the UK. I don't know.
Mark, any thoughts?
I suppose one of the things that strikes me, in order to have a vibrant hotbed of innovation and development in any kind of system, you need three things. You need people who've got really good ideas. You need people who are able to kind of articulate the requirements of customers who are able to buy stuff. And you need people with deep pockets and deep technical expertise who will enable you to have an effective route to market. And I have been, constantly impressed by the ideas that emanate from the UK. And my area's speciality is around data and informatics. But I've seen some awesome things happen. I mean, I was responsible for some of the open data initiatives that we were talking about earlier, and some of the work that was done with some of that open data initiatives was just fantastic. What we don't do, however, is make the route to market very easy. So I'm not going to start talking about procurement rules and what it's like to sell to the NHS. I think most of us have all gone grey on the basis of that particular subject. But the other one is around accelerator sites, innovation support, around access to venture capitalists, access to kind of route to market expertise. And recently I've been spending a little bit more time in the States, and what I've seen is an incredible difference. The idea is the same. People coming up with really good ideas and doing innovative and sexy stuff. But my goodness, the difference in the States in terms of them putting an ecosystem around it that allows them to kind of flourish. And what we do was kind of pat people on the head and say, there, that's a really nice idea. I bet you never get it to market. So I think we've got a way to go. But things like, I think the things like personalised care, I think things like open data and transparency and some of the kind of recent initiatives around the appetite for information, both on an individual patient level and on a population level, I see as being quite optimistic, actually.
Adrian?
Thank you. Adrian Condrick, Hitachi. 3 comments. I have to admit that in the past I have run an NHS procurement department, so I have understood some of those things, and it has turned me great. But there is a new thing coming out in October called co-development, where some of those rules about, the industry and others, I'm thinking particularly about SMEs, investing time with the NHS, they create something great, it goes to market and the lowest price wins.
Yeah.
Some of those rules are going to change, so I think the comment there is it's getting better. And 2 comments on the emotional front. Those of us who are old enough to remember when unleaded petrol first came out were told it would take 20 years for it to be readily available because the commercial angle on it wasn't strong enough. The public demand for it meant within 18 months we could all get unleaded petrol. That's the kind of thing we're looking for in the big data. The final comment is on the emotional impact. We talk about trying to change people's lifestyles and get them to engage with the process. I heard of something recently where there's, in diabetes, in one of the areas of Manchester we're working with, they have a very high profile diabetologist. And Morrison's put a cardboard cutout of him next to the vegetable store that reinforced the message about more vegetables, better care, and their sale of vegetables went through the roof. So let's not forget the emotional hooks. We're talking about the big data thing, but it's getting people to engage with that to change their behaviours. It's every route we can find and use the data to provide the evidence. But there's something about real sort of poppy thing, cardboard cutout, got the result.
Could you just say something more on the co-development side there? Just on the co-development side.
Not what it's a procurement thing. I'm happy to talk about it. I think there's much. Well, we'll catch up.
I think your final point as well, and you made it in the plenary session as well, about the kind of the Tesco's club card piece, and actually how can we utilise big data as a way to try and encourage people to change their behaviour. Is there there's a fine line between kind of being too involved in people's personal decisions and their lifestyle decisions, but then helpfully nudging them the right way. What do you think in terms of which side of that we should be falling, given the current situation in terms of public health and lifestyle choices?
I think we have to be really careful about how we behave as Big Brother, looking into people's lives. I think there's a whole raft of literature of which the cardboard cutout would fit on behavioural economics, which I think would have something to say about some of these things. If you've not read it, Nudge was a really interesting book on how to affect people's behaviour without regulating, which was a past interest of mine. So I think we have to be very careful about doing too much of that, and sticking to. I think we have to explain the benefit before we do it. I think just going out and doing it will just raise the barriers. That would be my only comment.
Okay. Stephen?
Yeah, I mean, I agree. I think we have to be extremely careful on strictly voluntary basis, that kind of stuff. I think it would probably, it's one of those things which would be an excellent idea in theory, probably might fall down on the practicalities. I mean, just thinking, focusing, taking that as a literal example, people tend to shop at the household level, not the individual level. People don't just stop at one store. They'll buy a bunch of things from places where they haven't got a club card, so you won't get a full record of their diet. There'll be a number of constraints which probably would make it viable. So I would err on the fact that it's probably an ambition too far, and with the concerns around becoming a Big Brother thing, it's probably something we would wait for, I think, rather than go for now.
Mark, given you were a practicing GP as well, do you think data like that would have been helpful in terms of advising, treating patients?
So I probably have a different perspective, actually. So I suppose I'm sort of conscious of the language of passivity and the language, as opposed to co-producing with the public and indeed with patients. We need to be really careful that we don't kind of fall into a world where we view the UK public as kind of data cows to be milked for us to kind of.
Lovely image.
I've never used that image before. I'm never going to use that image again. Actually, it's making me feel really uncomfortable just thinking about it. But do you know what I mean? That kind of that we're just going to kind of take the stuff off them and we're going to do something with it. I think that feels like a really uncomfortable place, and will lead us to all sorts of accusations around Big Brother, let alone big data. But there is, however, absolutely no doubt that where people see the value in terms of their own lives or the lives of their families, that people are willing to enter into the social contract of I'll give you some data if I get benefit. So every day as a general practitioner, and in fact I've just stopped being a general practitioner for the last 25 years of being a general practitioner, people came in to see me and there was a social contract by which they gave me data, and I used that data to guide and inform interactions I have with patients. So probably the most effective thing that I have ever done as a general practitioner is talk, in terms of outcomes and in terms of cost, is talk to people about their smoking behaviour. And I can only do that by knowing someone smokes and knowing about their smoking behaviour and bringing it up in a contextually relevant way. There's all sorts of issues around how you raise that, but certainly that's an example of using data for someone's benefit and ensuring that they are brought into that exchange. But can I just tell you two stories which I kind of shaped my thinking around this? Well, one was turn the clock back 15 years. We had a new practice manager in our practice. We had a very active patient participation group, and he decided that he was only in post about about sort of a month or so, and he decided he would take the patient participation group around the practice. And it's a big practice. There's 20,000 patients. So he took them around, the kind of QOF, the people that did QOF, the medical secretaries, the summarisers, the receptionists, all the staff who did all the work, the receptionists, and led this group of elderly, they were actually tend to be quite elderly people, round the group, sat them back in a room to sit back and bask in the praise about what an incredibly well organised practice this was, and how efficient and how great and how lucky they were to have such a great practice. And they were furious. And what they were furious about was the number of people who had seen their confidential data. Because when they went around the practice, this is a small town, they saw their neighbours, their brother's boyfriend, the person who lives down the street. We are one of the largest employers in the town. And they were really angry about the number of people who, because they had this kind of image in their head when they sat down with the general practitioner or the practice nurse or whoever the clinician was, there was a kind of one-to-one kind of conversation that was going. I mean, I can't type, but Lord knows how they thought the letters happened. And I was wheeled out to kind of placate this angry group of pensioners, and it was fascinating for me. I just because they were so angry, and I kind of had no understanding about why they were so cross. And in that moment, I realised that the value of treating people like adults, the value of transparency, the value of explaining to people in a mature way how we do business. And we had never done that in our practice. We had never explained how an organisation works, bound by governance, bound by rules, bound by the rules of confidentiality, and we work in a skill mixed team environment. We had never had the conversation. Wind the clock back forwards 15 years in the middle of the head of data debacle, as it was described, and we had a rerun of exactly the same issue. HES data had been collected since 1984, I think, something like that, and that data had been pseudonymised and shared with particular parties for particular processes with very strict governance and very strict rules. But when some of those stories started to come out about how some of the HES data, people were angry and they were shocked and they felt let down, and there was a kind of very similar kind of, well, why are they surprised? What's the problem? So, give an example. PA Consulting. I've got some. Well, why shouldn't they have? We've got a legal basis to do that. Well, there's a sound governance system to do that. And what's the problem? And of course, the problem was twofold. One is, we had never had, as a country, I'm talking Parliament now, had a mature debate about why and how we use data and why there's a requirement there. And there was a mismatch in the language, which was I found very interesting. So when you talk to information governance experts, and we've got a few in the room at the moment, they talk, their bread and butter is purpose. So what drives information governance legislation is what you are using the data for. If you talk to lots of members of the public, what they talk the language of who's got my data, and in our legal framework, actually, there's no way of us defining who. So an insurance company, so giving an example, Bupa, an insurance company, if they happen to be providing commissioning support around a particular locality in order to redesign services, information governance terms with the right controls and etc., that might be an entirely legitimate thing, but when it gets reported on a broadsheet, it becomes an insurance company having data. And there was a significant mismatch, which goes to the heart of what I was saying about the emotional stuff and getting the emotional narrative right.
On that point and following on sorry, I'm Claire Sanderson. I run an information governance consultancy firm, and I was an ex-colleague of Mark's at the Health and Social Care Information Centre, where I was the Executive Director of Information Governance. I'm probably one of the most hated persons in the room at the moment. Hopefully what I say will make me less hated. I think your point there is really, really critical to all of this. If you're talking big data in health, we've got to bring the public with us. It's not just about the government doing that, because one of the things that the public hate more or equally as much as the government is commercial organisations who they believe are the most unethical people in the world. None of this is well founded. We talk about your fear of crime as a member of the public is greater than your risk of crime, and that's exactly what's happening around this sort of situation. So the privacy lobby has got the ear of the public, has got the ear of the press, and they have set the scene, if you like, and we've got a big mountain to climb. But I think we can do it, and I think we can do it by bringing out very much the benefits to individuals, to society, making sure that people do know what's going on and that we aren't just not telling them because we've got something to hide. And the third thing I think we maybe need to do, and this is probably quite controversial, but hopefully you'll come with me, we need to make the penalties greater. So one of the things that the public are really, and certainly the privacy lobby, are not convinced about is if you have big data, you have information, you find something out about somebody, or you go to find something out about somebody, you get slapped with a fine, which is a minimal fine. If it's from the Information Commissioner's Office, it could be up to 500,000. As far as the public's concerned, for a big pharma company, that's peanuts. And if they can use that information to start targeting people about their drug, all those sorts of things, and they've got this. So if we made the penalties more fitting to the crime as the public sees it, then maybe the public would come along with us a bit better.
I would disagree, I'm afraid, entirely with that last point. I think the public, especially around this area, I think the whole idea of regulation and penalties will not be something that earns trust.
So you can't do one without the other. I'm not suggesting that at all, but it's a backstop situation. Right?
And we do. The risk is if we follow that route, we end up in a position where, for example, the punishment for that pharmaceutical company because they've done something which breaks either the current or any new data protection laws, they may end up being more severely punished than they would be for corporate manslaughter. So, which was the original European Commission's proposal going back last year. So I think we have to be careful about how much we use the idea of a big stick, and also how much that actually appeals to the public, and how much they would take that into account when thinking about the use of their data.
Yeah. So I agree. I think there's possibly even deep-seated cultural reasons why there's that scepticism about large organisations and government, which we're not going to solve through anything. But one perspective I think we've seen in other industries is the idea of empowerment. So one of the things that upsets people is the fact they just seem to have no choice about this. They go about their life. Trying to get off the grid, if you use that phrase around, how do you stop producing a data footprint in your life? It's impossible. You have to really disrupt your life and change your life to stop generating data. So I think there's a lot of resentment around the fact that people suddenly they look up 5 years later and suddenly data about them is everywhere and they didn't know that. But just giving people the power back to choose what the data's used for and where it is, and the transparency and empowerment will mitigate to an extent now. I think that's one thing you need to look at for this is how do we empower people to say what this data is used for or not, and make that really simple and really easy for people. And I think as you've seen in other places, what happens then is people just ignore it. So they don't then empower themselves and turn the data off. They leave it alone, but they've been given the choice. And once people see they've been given the choice, they feel there's less to hide on the other end maybe. So that might be one of the routes to solving the problem maybe.
Okay. Gentleman at the back.
Yeah. Excuse me. Steve Leggett. I work for a healthcare IT organisation called techUK Limited. I just wanted to make a point about, this is weird because I feel like, when I used to be in the NHS, I feel like I'm back in 10 years ago, in 2003, and, MP Fit is kicking off, and it feels like we've done a complete turnaround and we're back at this position again, and we've spent lots and lots and lots of public money to not really get us very far. So whilst I completely get, and I'm hugely behind the whole idea of data and what we can do with it, and capabilities of change, and there's clever people out there who can do some fantastic stuff. When you talk population health, things, and you're talking about cardboard cutouts of vegetables, it's fantastic. But population health can go further to the point where we can look at demographics and look where fast food joints are. What people's diets are coming from supermarkets and restaurants and all that sort of thing that can help us to better inform how we care for the population. My point would go back to a couple of things really. Do we think the public have got a generally very apathetic view to what we're trying to do, given we're 10-year cycle down the line and we feel like we're starting again to some degree. And there's and then allied to that, things like very recently, do the public trust what we're trying to do when you've got eBay being hacked and all of them to change passwords, when you've got PlayStation Network being hacked a few years ago and credit card details being lost? Is there a general fear, and is that fear aligned to, I don't know, maybe we've even still got a percentage of the population who haven't had any formalised IT training, and they're now starting to roll out the population. That sounds awful, but I think you get what I mean. Is there a generally apathetic view to what we're trying to do is going to get us in our way? And when you think about the why, because I think that's absolute key to what we're trying to do, getting that out there to the public, do we have to combat that apathetic view with to get to the why?
Okay. Anyone want to go first with that? Richard, is it like you're ready?
I agree. And I think we've partly never taken on the argument, which is why we're seeing it cycling around again. I think, not to wish to keep mentioning care.data. I think for me that was a bit of a turning point in the tenor of public debate about data in the UK. We saw a whole succession of revelations from a gentleman called Edward Snowden, which caused enormous ripples in some other countries in the world, and so far as I can see, excited almost no one in the UK. And the attitude seemed to be spy, so big deal. Which must have been a real disappointment to the kind of media outlets who were pursuing that agenda. But I think care.data actually showed that the British public do care, actually, and what they do care, what they do have is a very risk-based idea of what data they're prepared to share and what data they're not prepared to share. And health data, for better or worse, sits right at the end of I don't want my health data being shared anyway. Having GCHQ or the NSA finding out who they're communicating emails with doesn't seem to upset the UK population for lots of cultural reasons. I'm sure we haven't experienced the same things here as many of our continental partners, but we have also experienced some things that they haven't in terrorist terms. So I think we've never really taken on the issue, but partly because it's not been an issue, I think, but now it is, and I really think we have to take it seriously. But I do agree with you.
I think I'm really glad that you mentioned Snowden, you mentioned the new program for IT from 10 years ago, because I think there is this curious disconnect between the two things, and I think the public disquiet maybe around care.data may not be rooted through coming from those kind of core privacy concerns which relate to the Snowden stuff. I think it's more the narrative we've had the last 10 years of governments trying to do things with data and not succeeding very well. So we've had a number of controversial database programs through different bits of government in the last 10 years, which I think has built up, certainly in the media and maybe the public's imagination, more than the risks around Snowden. So the RT program had a high profile fallout, I guess, around that. We had things like the Connect database, remember that one, around children at risk and bringing all that data together. That was very controversial. We had the potential national ID database, which got scrapped. And these are the big political arguments which were had, and the government was seen to be on the wrong side of that debate from the public a lot. And I wonder whether we're just a little bit at we're kind of a victim of that. That story's trickled through the last 10 years. There's been a real centralising agenda around databases which hasn't worked well with the public, and now we've got this, and it's part of that. It is curious how then Snowden, which is like the mammoth of all sort of central databases, hasn't resonated because it's not been seen as a UK government trying to do something and failing. It's already there and happening. What do you think about it? And that seems, and I think that comes down to the point about apathy, that fundamentally when something's there and it's done, people haven't been worked up to complain too much about it. But when there's a proposal out there, a white paper for let's pull this data together for national identity database, enough people mobilise around it for it to become a real issue. So it's a curious mix, I think.
Mark, any?
So no, I think you said it very well, really, and I guess
I guess if care.data did anything, it was very effective in setting aside the apathy that was there from the general public around health data. So I said in my introduction that one of the things that we needed was a mature dialogue around the use of data. Well, actually, when you have a mature dialogue, it's difficult, and there's disagreement, and there's balances to be achieved, and there's some kind of hard-nosed conversations to have about risk and benefits, and that's what we're doing at the moment. That's where we're in as a democracy, and actually, frankly, I welcome it. I think it's going to take as long as it takes, and there's an important debate to be had. Also, as a GP, I would reflect on the fact that when someone comes to see me and they trust me because I hold their data. As a general practitioner, I wonder what people really understand as that, because obviously the system that I use is a distributed system with a kind of large data warehouse somewhere in the country that kind of holds it. So I think there's a bit of a mismatch between what people think is going on and what's actually happening using modern technology.
Okay, I'm just conscious of time, so I think we can have the last few final questions. The gentleman here in the corner.
Yes,
and then
Phil Young from Waters. I just, when you were talking about predictive analytics at point of care, and the use of big data then to kind of elucidate some answers, how much do you think regulatory bodies like the FDA are kind of keeping in step with those type of developments? Are they kind of years away from regulating that type of market and those type of products? Or are they kind of really on the cusp of it and kind of up with it?
So thank you for that. So I think it's tricky, and to be honest, for those who have worked in regulation previously, it's difficult when it's like trying to change the wheels on a bus when the bus is moving, because things move really quickly, and regulation and other national bodies like NICE, for example, kind of grumble along at their own, and it's difficult for them to keep up. Certainly the conversations that I've had with the FDA and the MHRA around kind of app development, for example, there's an absolute acknowledgement that the current regulatory frameworks that we've got need to move and adapt to embrace the kind of current opportunities that we've had. So having a definition of a kind of medical device, not a medical device, that kind of binary thing isn't really helpful, and we need a continuum of maturity, if I can use that expression, around apps, for example, that takes you from very simple information stuff to stuff that's presenting contextually relevant information, to stuff that perhaps starts to use data points from your own personal records, to stuff that is absolutely a device and an app, and we need a kind of continuum of regulation that is proportionate to what's going on. And I see a similar thing happening on the big data predictive analytics at a population level as well. But those conversations are happening, and the regulatory framework that we all love and enjoy is acknowledging that it needs to move and adapt as the technology changes.
Okay. Anyone else have comments?
As a general point, I would say the more prescriptive you make a particular regulation, and this doesn't necessarily apply to the situation we've been talking about, but I think it could, the less it has an ability to adapt to changes. So if we regulate based on broader principles and outcome, then I think you have a framework which is more adaptable. Unfortunately, there's a tendency to try to regulate for at a very prescriptive level for every eventuality, and that's before it's passed, it's out of date.
David Hughes, University of Chester, healthcare decisions. The issue you alluded to actually about, funnily enough, Bupa commissioning, providing risk stratification support. I was a director of Health Dialogue. Now we followed all the IG guidelines. There was no risk with these data, but the two things we did wrong was, one was being American, and secondly was not taking the public with us, and that really is what did for us. Pharmaceutical companies work a lot with pharmaceutical companies, and again, I've never thought of that. It's not about the purpose, it's about the who's getting your data. We have to be very rigid about what the data is being used for. It isn't being used, in my experience, with pharmaceutical companies to go and milk the population to try and target them with their drugs and force. It's not. It's very strategic what they actually do. But one thought struck me. We're doing some work at the moment, and again, it's probably the point I was making before with the commissioning support unit, supporting clinical commissioning groups. We've spent 5 months trying to get their own data from them. 5 months trying to get because they just are trying to get through these damn hoops. We're trying again to link it again, data that already exists. Now, if we don't try this emotional response we have to not allowing data to be used, it is the big thing. I'm reiterating what you're saying, but it's the really, really big issue that is not new. It's been around for years and years and years. Collecting more data, we've got to get around over this hurdle pretty soon, because it's stopping us doing from what we're doing. The emotional response the gentleman's made of using the market. Pharmaceutical companies are motivated by that commercial drive, as was the US company that I was a director of. But we were motivated. The return on investment that the actual work we did was in the Northwest was showing a £1.9 return for every pound spent. And this project was pulled, and it was pulled because people didn't want to share their data, and they actually retrenched back to the US and said, well, okay, we're not playing in the UK anymore. So we've actually done a disservice to the health system there and spent 90 pence more per patient than we should be doing across the system. So.
Any final comments from?
Claire wants to say anything.
Claire?
No, I mean, I absolutely agree. We have got a battle to bring the public with us, but as I said before, it's a battle It's a thing for us all to do. We've all got to do it. The pharma companies have got to do it, and so on and so forth. It is around the ethics of what you do. I don't distrust what you do. I know a number of companies, and I work with some of them, and they do look after people's data, etc., etc. But the British public is very suspicious of it and I think a lot of it's around the care.data. And they believe if you don't tell them what you're doing, then you're doing something that you don't want them to know. And we've got to move away from that. It's a big cultural issue.
I think that leads into my just final question to the three of you for kind of concluding remarks, which is actually if there was one thing you could change around the current landscape to really unleash the power of big data, what would it be? And I'll hand it over to Mark in the first instance for a kind of 10-second response. I'm just conscious of time.
Yeah, I don't think I've ever in my life said anything in 10 seconds.
I'll give you 20.
Yeah, no, you. Well, we've got on the spot. I don't know is the honest answer. I think there's. I was really struck by what the gentleman from Cerner said about the national programme. I was thinking about the kind of what the experiences of the national programme and the experience of this. And there's something around getting the geography right about this stuff. You know, what are the things that are best done national? What are the best things that are best done regional? And what are the things that are best done on a very local basis? And you know, actually, although I work nationally, some of the best things that I have ever seen have been when the NHS and social care works on a very local level. So I guess if I had one plea around moving this conversation forward in terms of the utilisation, the benefits, the risks, and the engagement, it's that we concentrate on that very, very rich resource that we have, our communities and neighbourhoods and our small localities, and we use that as the building block to build the story.
Lovely, thank you. Richard?
Okay, well, so if I woke up tomorrow and I think had one thing, it would be we magically achieved this view in the public's mind that big data was potentially a good thing in all kinds of ways. It isn't just in healthcare that this is an issue, but in healthcare it happens to impact on people very personally. But I think that whole cultural shift would be the thing I would look for.
Okay. Steve?
Who's the guy in Mad Men? What's his name? The lead character?
I don't watch it.
Don Draper.
Don Draper.
Don Draper.
Don Draper, that's right, yeah. So I mean, if I was to do one thing to improve this, I would triple the advertising budget for care.data with Don Draper in charge of the campaign.
Fantastic.
Can I have another one, actually?
Very quickly.
It was very funny, actually. I was in a meeting a bit like this. I was chairing a group of public health people, and we were talking about the kind of ways to go. And some bright spark at the back said we should have taken the budget of care.data and bought the Daily Mail, which I thought was
fantastic. Well, I think we've covered a lot of issues in the hour and a half that we had. So thank you very much to the three of you for partaking in the session. I think there's a lot of challenges that has obviously been identified, and the care.data issue around privacy and trust is the most prominent. But I think it's also a lot of positives to be taken out of the discussion as well, and lots of opportunities and benefits around capitalising on big data. And one of the things that techUK as a trade body does is actually absolutely kind of look at how can we do that. And how can we make sure that the kind of healthcare professionals understand the value, but also how can we support the industry in communicating best practice in the pockets and areas where there are demonstrations of the real benefit of big data. So I've certainly taken a lot from this session, as I hope you have done too. But just a final request to thank our speakers in the normal way.